Hello, my name is Alex Wynn, and my presentation today was completed alongside Abel Haj, Hanyu, and our attending Dr. Ganaga. We are residents in the Department of Emergency Medicine at Henry Ford Wyandotte Hospital. Our case report is titled Acute Limb Ischemia and Totally Occluding Acute Deep Vein Thromboses in COVID-19. So acute limb ischemia can be defined as a decrease in limb blood flow and hypoperfusion due to occlusion of a peripheral artery from a thrombus or embolus. While the mechanism is still very unclear, COVID-19 infection is associated with endothelial dysfunction, inflammation, and cytokine release that leads to a hypercoagulable state. Prognosis for the extremity and the patient is poor unless rapid treatment occurs. Classically, the 6Ps mnemonic is used to provide the clinician with clinical signs and symptoms to be cognizant and wary of. These include pain out of proportion to exam, pallor, pulselessness, paresthesias, poikilothermia, and paralysis. As for the case presentation itself, we report and discuss a case of a 69-year-old female with past medical history significant for well-controlled type 2 diabetes who presented to the ED with acute onset left lower extremity pain that started 8 hours prior to arrival. She described the pain as burning and throbbing and rated it 10 out of 10. She denied injury, trauma, or other precipitating events. She denied all other symptoms. She lived an active, non-sedentary lifestyle. She was a lifetime non-smoker with a normal body habitus. She denied a history of atrial fibrillation, blood clots, or known coagulopathic disorders in herself or her family. She denied recent travel, surgery, or immobilization. Her EKG was normal and vital stable. She was afebrile and not hypoxic, tachypneic, or tachycardic. She had no popliteal, DP, or PT pulse with palpation or Doppler. X-ray of the leg showed no acute process. Labs showed no derangements except for her COVID-19 RNA test, which was positive. She was transferred to a tertiary care center for evaluation by a vascular surgery team and escalation of care. In the image to the left, you can see a grossly abnormal left lower extremity that is obviously swollen, edematous, slightly mottled, and erythematous. The CT angiogram to the right shows obvious occlusion of the left iliac vessels as they descend. As for the interventions and results of the study, left lower extremity venous imaging performed showed totally occluding acute deep vein thromboses of the external iliac vein, common femoral vein, deep femoral vein, popliteal vein, posterior tibial vein, perineal vein, and gastrocnemius vein. CT angiography showed occlusion of the left common and external iliac arteries, the left popliteal artery, and the distal arterial vasculature. She did have multifocal ground glass opacities in her lower lung fields. She underwent successful thrombectomy with no complications or issues of note. From a COVID-19 standpoint, she was treated with Solumedrol and Remdesivir. She was ultimately discharged home on aspirin, Plavix, Lovenox Bridge, daily warfarin, with plans to follow up with a primary care provider and vascular surgery on an outpatient basis. As for the discussion and considerations, COVID-19 presents with a myriad of clinical manifestations ranging from an asymptomatic carrier state to severe respiratory distress, multi-organ dysfunction, and ultimately death. COVID-19 predisposes the infected patient to a prothrombotic state, resulting in both venous and arterial thromboses. This is thought to be from a severe inflammatory response leading to micro and macrovascular changes. Good prognosis and survival is dependent on very early evaluation as well as rapid intervention. Per the literature, the prevalence of acute limb ischemia in COVID-19 infected patients is 0.54%. To our knowledge, there are no reported cases in the literature of a patient with asymptomatic COVID-19 infection with concomitant acute limb ischemia and totally occluding acute DVT. It's critically important for the physician to be wary of the hypercoagulable pathologies associated with COVID-19. As seen in our patients, these life-threatening issues can present for the first time in those asymptomatic from a COVID standpoint with no risk factors. A high index of suspicion for these disorders must be maintained, and they must be included in the differential diagnosis as time is truly limb and life. And last but not least, our references for your consideration. Thank you for your time and attention.